Welcome to our webinar tonight, where we're going to discuss developments in diagnosis and treatments in prostate cancer in 2020. I'm Graham Woodside, Chief Executive of the Prostate Cancer Foundation, and along with my colleague Raywin Pavia, we're pleased to be hosting this webinar with you tonight. We've got two main objectives with this webinar. The first is to hear from a special guest, a urologist, Dr. Liam Wilson from the Bay Urology in Tauranga, on what is happening with prostate cancer in New Zealand, and we'll come back to talk to him soon. And secondly, to introduce two prostate cancer survivors who are restarting a support group in Tauranga because they really want to help others who are travelling the same prostate journey and provide them with support and camaraderie. So it's my pleasure to introduce firstly Ian Armstrong.
Hi everyone.
It's Ian. And Pete Robieson.
Hi everybody.
Ian, let me start off with you. Tell us a little bit about your experience and what's motivated you and Pete to get involved starting up a support group in Tauranga.
Sure. Thank you, Graham, and it's a pleasure to be with you all this evening. I'd like to cover some background to the Tauranga support group and why we're doing this, and Pete will cover more of the operational matters. But firstly, my prostate journey. It was totally unexpected, as I'm sure happens with many men. It started in 2018. In September of the previous year, I was pretty active. I run half marathons. I was going to gym 5 times a week, and I had no symptoms. I had a PSA test in September 17, and that was normal. I fast forward 5 months to February 18. Every February, I have my annual medical, and my PSA had quadrupled. And from the digital test, there was a hardening on one side of the prostate. So my journey began. Following a successful prostatectomy, I was told my Gleason score had gone from 7 pre-op to 9 post-op, and my cancer stage had gone from 2 to level 4. I had a number of scans, and we were given the news that nobody wanted to hear. Not only was the cancer aggressive, it was an incurable form. So now I'm on tests and treatment for the rest of my life. But I consider myself very lucky, as once I'd recovered from chemotherapy, I was able to get back to an active lifestyle. I'm doing half marathons again, I'm back at gym, and I have an amazing group of close family, good friends, and of course my wife Patty for support.
Thanks, Ian. Just let me bring Pete in now. Pete, tell us a little bit about your journey with prostate cancer.
Yeah, good evening everybody. Great to be there. My journey started roughly 5 or 6 years ago when I started having standard 6 monthly blood tests, what I called my warrant of fitness. My PSA continued to slowly rise over this period, and finally my GP recommended a visit to my urologist for professional intervention. Prior to this first visit, I had no symptoms, and I think the term is asymptomatic. Felt well, no toilet visits over and above what was considered fairly normal. Anyway, wind on from here, I then had an MRI, which we were advised was all clear, and then next had a biopsy with my urologist. These test results detected that I did in fact have a low-grade prostate cancer, and so things changed from here. I was advised of 3 possible treatment options to consider, and in late September 2019, I then decided to have a radical prostatectomy. Pathology results came back after the operation, indicated that in my case, I was extremely lucky that my cancer was totally contained within the prostate. From here on to date, I've continued to have what I consider a good recovery. And next up, I have another follow-up visit with my urologist for another PSA test in a couple of weeks. My thanks go out to my urologist and especially to my anaesthetist, as I told him prior to my operation that I didn't want to wake up during the operation. And this he achieved well. So yeah, that's where I am today.
That's great. So Ian, how did you link up with Pete to get together and work on this project of restarting the group in Tauranga?
I met Pete socially several years ago through mutual friends who were also going through their cancer journey. But it was early in his journey. I got to know him and his partner Ruth quite well. And hopefully Patty and I were able to give him some support based on what we'd been through. But it was during this time of our journeys that we realized the support group was missing in Tauranga. And we felt if our experiences were anything to go by, there was a crying need to have a support group here. So whilst the medical and nursing assistance pre and post our prostatectomies was excellent, we and our partners missed being able to talk to men and couples about their experiences, share stories, and realize that we weren't on our own. So we contacted the Prostate Cancer Foundation, and we learned that Tauranga used to have a support group, but when the coordinator moved from Tauranga, the group essentially dissipated. So we made it our mission to resuscitate the group. Our plan is to re-establish the support group for Tauranga, for people based here to meet, help and support each other and advance the aims and objectives of the Prostate Cancer Foundation. So Pete and I looked at what a Tauranga support group could look like. We spent a few months engaging with the Prostate Cancer Foundation, primarily through Raywin, and with Judy Kelly, who's a urology nurse here in the Bay. And we developed our plans. We had our marketing plans, we had a venue, we had our initial thoughts on running the group, and we were all ready to activate it when something called COVID came along. So that put us back several months, but we're really pleased that Raywin and yourselves suggested that we hold this kickoff Zoom meeting, and hopefully we can now get things going.
So COVID now is starting to dissipate, it seems, and it looks like we might be getting some good news about dropping a level next week. So might be able to get the group started. Pete, tell us a little bit how you see that group functioning.
Yeah, as Ian said, we were ready to rock and roll quite a few times actually before COVID actually came along. We'd had various meetings and plans and venues and stuff like that we'd thrown around. So now we're here, we're hopefully come July or at least August, we can have our first physical meeting. And I'd like to just take you quickly through how we see the support group operating. First, let me say that we're not wishing to be prescriptive on how the group will operate, and we'll be guided by what members want. Based on meetings we've had with other support group coordinators and the PCF input, we'd suggest the Tauranga support group would have the following operating model. We've secured the Tauranga Club in the Devonport Towers, Devonport Road for meetings, which should be on the first Monday of the month, except January. We believe this is reasonably accessible. This is a reasonably accessible venue considering the geographic spread of the Tauranga region. First two meetings would have snacks and drinks format. We would get to know future members and to talk about the operating model. We're very open to changing some things based on the needs of members. Thereafter, we propose to have dinner meetings, drinks beforehand, and a meal which would cater for all budgets, either an easy light meal, something more substantial, or nothing at all. We suggest starting at 6 and finishing around 8 o'clock. We feel that meetings should be open to partners, and in fact, they should be encouraged to attend. Our journeys are not ours alone. The format of the meetings will vary, sometimes a guest speaker, other times discussion forums and sharing amongst other people, sharing each other. Once we have an active group, we'll look at how to support the PCF with local fundraising events. We're really just ready to see what people want and adapt the direction, to cater for that.
And it looks like, it may be able to get underway first Monday in July. I think it's about the 6th of July or something like that. But we'll put some details in the email that we'll send out following this webinar. And certainly there'll be an opportunity to register interest. Guys, look, we really thank you for taking on this role. We've got about 38 groups up and down the country, and to have one in Tauranga is really important to us. So I know that you'll have plenty of men from your region, and I know a number of them are watching this webinar tonight who will be really interested in what you're doing and will want to get behind you and support you in that. So thank you very, very much. So all the details of this Tauranga group will be on our website. and Ian and Pete's contact details will be there. And as I said before, also in the email that we're going to send you following. So, gentlemen, thank you.
Thanks.
So now we come to the second part of the webinar, and I'd like to introduce Dr. Liam Wilson. Liam's been a urologist working in Bay of Plenty since 2005, and he's got a particular focus on prostate cancer in his clinical work. Welcome, Liam.
Graham, thank you. And I just want to echo your words to say thank you to Ian and Peter for a sterling job, and Raywin to organise such a great event under such interesting circumstances, and to see the turnout. 70 attendees and counting. I'm scrolling the attendees quite nervously. There's a lot of talent in this attendees list. People who I should say should volunteer for a future night. I'm looking at Judy Kelly, and I'd like to just take the opportunity to say introduce Jessica Parks, who's our oncology nurse who's got more time through the public system, and she's a wonderful asset for the men of Tauranga with regards to prostate cancer and all urological cancers. So thank you for inviting me, and we're going to talk through a few topics, and as we go, if you have any questions, sing out.
Yeah, so let's kick off. Let's start with the testing and the diagnostic process. It seems to me, certainly in the few years that I've been involved, there's some real improvements here. So tell us just what's happening in testing and diagnosis.
Sure. Look, let me just try and share a document with you. My computer got dropped by one of my family members yesterday, so I have my teenage son's computer. What could go wrong? So probably the most important change in diagnostic tests for prostate cancer is the MRI. Historically, there was only one thing we could do, and that was a transrectal biopsy. And when it's the only test you can have, it is what it is. But one of the criticisms of PSA testing is the over-diagnosis or the overuse of biopsy, because a transrectal biopsy, if it can be minimized, or the number of men who can have one is minimized, that's of great benefit. So this is an MRI, and what MRI does, it tells us what's going on and what is the likelihood of a lump in the prostate being significant. So let me try and again use some newfound technological wizardry just to orientate you. These are the hips here. This is a cross section of the pelvis. The prostate is here, and it's interesting, I can still have a shake going on during a video presentation. I'm still nervous. This is the rectum. So a transrectal biopsy is taking samples of the prostate there. What this MRI shows is that there is a large area, this black area here, which is well away from the rectum. So trying to hit that with a transrectal approach would be difficult and uncomfortable. So an MRI, what it does, it tells us what's going on in the prostate. It's not perfect. And we just had a discussion before we came on air about that. So an MRI will detect prostate cancer about 95% of the time. It detects significant cancer, so it's good at finding important cancer and not finding cancer that's less important. We'll talk a bit about that later in active surveillance. But it also tells us whether a transrectal biopsy is the way to go or a transperineal biopsy. Now, I'm talking about the Bay of Plenty. Unless I say otherwise, I'm talking about the management of public patients in the Bay of Plenty, both here in Tauranga and Rotorua. So if you're dialing in from somewhere else, what you experience may be slightly different. But in the Bay of Plenty, most men referred through the public system will get an MRI before a biopsy. And that's the way things will go in the future. The downsides of MRI is that it is expensive and it is a wanted test, so there is a queue of people, but it really has changed how we approach diagnostic tests for prostate cancer.
Okay, so that's fairly routine. Now, one of the things I do know that up and down the country, it's not funded by everybody, and that's one of the issues that we are advocating for. In some places, men are asked to pay for an MRI, which I think is unfortunate. But certainly in your situation, they're being used almost, and certainly in all, I understand it, they're being used pretty much routinely pre-biopsy. Let's move on to another scan that's really come on the horizon in the last few years is the PSMA scan. And that's been hailed as a game changer for diagnosing potential spread of disease, both at diagnosis and following initial treatment where there's a potential for recurrence. How are you using PSMA scans?
A PSMA PET scan is different from a plain MRI or a CT scan. It actually tells us what's in the lump we can see. And so PSMA, as the name would suggest, you get injected with material which binds to PSA wherever it is in the body. And that shows up, if you see on the left-hand side, a red arrow, that's a lymph node that shines up brightly. That is prostate cancer in a lymph node. And a CT scan or an MRI would just show that it's enlarged. A PSMA PET shows that there is cancer in that node, and that will change how we manage that patient. It's not 100% foolproof. There are limitations. It is expensive. It's not in every centre. We don't have it in Tauranga. It's not usually funded through the public system at all. And so some men elect to pay for it because it can change the type of treatment they have. That will change with time, but currently it is an expensive test. You can see on the right-hand side, the arrow is of an area in the spine, so a bone spread to the bone, and that would change management for a man who, with other tests, may just show that he has cancer in his prostate. So PSMA PET for staging, for looking for cancer outside the prostate, is a game changer. One
of the criticisms of prostate cancer treatment in years gone by was over-treatment or unnecessary treatment. So what's being done to minimise that in 2020?
So there are two types of prostate cancer, if you look at it in broad terms, and there is low-grade cancer. We call it Gleason 3+3, or ISIP1 is the new terminology. And the criticism of prostate cancer and PSA testing is that we find all this cancer that is not going to grow or spread or cause symptoms or shorten the life of men. And we talked about the MRI. An MRI can help to reduce the number of biopsies, so we find less low-grade cancer, but we still find low-grade cancer. And this Gleason 6 or ISIP1, it's what we call indolent. It's slow-growing, if at all. The chances of it causing men trouble is very low. And so men are always better off in that scenario, unless they feel very strongly, to have what's called active surveillance. And that is a system of monitoring with PSAs and MRIs and biopsies, because this type of cancer can be safely watched for many years. We call it active surveillance because that suggests that if there is a change in the PSA or a change in an MRI or a biopsy, that we change from a surveillance protocol to discussing active treatment. The other time that we would stop active surveillance is some men get sick of it. It can be a long process, and men can get sick of having repeated testing, but most men are happy when they're fully informed that monitoring is the best thing for them. And so when I was a boy, every type of prostate cancer got treated. You had surgery or radiation. If you were fit and active and had a good life expectancy. Whereas now, large proportions of men who have low-grade prostate cancer, we put them on an active surveillance protocol.
About what sort of numbers would be on active surveillance? Out of 100 men that came to you and were diagnosed, how many of those might end up on active surveillance?
That's a good question. So of the men diagnosed with low-grade cancer, nearly all of them go under active surveillance. The proviso is young men. So if you're 50 and have low-grade cancer, they might have a period of active surveillance, but they might go to 55 and say, gosh, I've got another 20 years of this is too much. But having said that, most men continue on active surveillance. So proportion of low-grade, so what we'd say is how many men are being treated appropriately by having active surveillance is very high. I'd say it's well over 90%. Mm-hmm. It's certainly, active surveillance is not for people with high-grade disease. That can lead to trouble in that prostate cancer can grow or spread. And so you need to be disciplined with who you put on active surveillance. There are strict criteria for it, but it is a very effective way of managing men.
You know, we take calls on our support line, and one of the relatively frequent calls is people who are facing the prospect of making a decision and active surveillance is being suggested. And they're torn between the decision of let's get rid of the cancer or how can I live with it? Right. Any sort of comments about how people should feel and how they should weigh up the balance in that area?
I think the key thing is there is no rush. And so it takes time for men, for everybody to get their head around what's going on. And, you know, as soon as you hear the word cancer, you think, goodness me, how can you say that doing nothing is the right thing to do? Mm-hmm. And so sometimes, in fact, it's always worth revisiting things because there's no rush, as in you can have a discussion, man and family can go away and think about things and come back and then have another discussion. So there are some men who don't like the idea and never like the idea, and they should be offered treatment. And so it shouldn't be a compulsory thing. It should be, there's some men who would benefit from treatment just for their peace of mind. And so, and the good thing from that point of view is that the chances of cure obviously are very, very high. So I think every man is different, and but time and repeat information is vital.
I just reinforce what you've said, first of all, Liam, in regards to what Graham is saying about the calls that come in on our 0800 number. And I think is that opportunity for the man and his supportive person to be able to go back and re-ask those questions or to actually get clarity. And I think you've really hit, you know, the nail on the head with what you've said in regards to that they feel comfortable and that they, you know, can ask questions regardless of whether they've already been asked previously. So I think that's very important from the calls that we get. Absolutely. That should be more or less mandatory. You should see them back and make sure that they're happy in their decision. That's great. So there are a couple of questions here. Liam, the couple first, the first is, how much is the PSMA PET CT test? Do you know what the cost of that is? Look, the last time I checked, it was about $2,600. It's not cheap. In fact, when it used to be that it was cheaper to fly to Australia and have the test in Australia. But no, look, we've got good quality locally in Hamilton and Auckland. We send men to, but yeah, it is not cheap. Right, all right, thank you. The next question is from one of the participants saying, after consistent fluctuating but high PSA results, I was referred for an MRI scan, which I had at Pacific Radiology in Palmerston North. The scan showed a significant indication of cancer in the peripheral area with possible effect in the seminal vesicule. Could you comment on that, please? Oh, look, you know, it's hard externally to comment, but I mean, the MRI is the right thing to do, and that helps with the biopsy and helps with planning any necessary treatment. But look, that's a good example of an MRI being very helpful. And I know you're not a radiologist, but there's been some real improvements in radiotherapy. Can you please talk a little bit about these, Liam? What is really interesting with radiotherapy is hypofractionation, which is the fancy term for saying they deliver the same dose with fewer treatments. So in a lot of men with prostate cancer, it doesn't matter whether they have surgery or radiation. The cure rates are very similar for a lot of types of cancer. There are a few exceptions, but one of the downsides, I guess, for radiation is that sometimes it was 5 days a week for 7 or 8 weeks, or 6 or 7 weeks. So quite a long course. Now, you could say, well, after surgery, your recovery's often about the same. But now with hyperfractionation, and it's been well studied, that treatment time is more or less halved. So not for all prostate cancer, but for a large proportion, men can have their treatment done in 4 weeks. And what's making Leanne and Donald Chan at the KKC even more excited is that the future is, it might be even shorter. So stereotactic radiation to the prostate, you might have the same dose with the same success in 5 days. Now, they're not at that stage yet, but that is quite exciting from a recovery and treatment time point of view, because some men struggle to have treatment 5 days a week for up to 8 weeks. Radiation is, like everything, progressing, and there are new and good things happening.
Yeah, and it's particularly those long period of time is particularly difficult for men who are not right close, as you are in Tauranga now, with a treatment centre, if they have to relocate for a period of time and things like that. And it can often be a decision based on convenience rather than on the preferred treatment.
Absolutely. Yeah, that's exactly right. So when we found that, when our closest radiation was in Hamilton, it was very difficult. Even though it's not that far, it is a burden when you're going, 5 days a week.
So next question, Liam, is what if a biopsy and an MRI conflict in that a biopsy reveals level 2 cancer, but an MRI doesn't detect it? The
thing with prostate cancer and PSA testing is that you never rely on one test. You never rely on a PSA. You never rely on an MRI. You have to take the whole thing into consideration. So as an example, one of the extra things we take into account is the PSA density, which is what is your PSA for the size of your prostate. So if you've got a small prostate and a relatively high PSA, that makes us nervous. If you've got a mildly elevated PSA and an enormous prostate, which is BPH, so just an overgrown prostate, which is benign, we're a lot less concerned. And so we never rely on one test. An MRI is excellent, but it does not, it is not biopsy, it's not tissue under the microscope. So if there are any concerns, you always need to default to a biopsy. So MRI can miss a cancer. It's not foolproof. It'll detect things 95% of the time usually. So another question is, I have now been referred for a bone scan. Is that the same as PSMA? I am also told by my urologist that he does not consider surgery to have a high success at eliminating it, and I am also on blood thinners, so there is a risk of bleeding. So apparently the next step is radiotherapy. They then actually said, I also forgot to say I've had a biopsy which confirmed the above. Again, that makes a lot of sense. So firstly, the bone scan is a good test, all right? A bone scan is a test to look for spread to the bones, which is a common place for prostate cancer. It is available. It's not as good as a PSMA PET, but it is a good test. If there are concerns about the success of surgery, it is much better to have radiation. Radiation for prostate cancer that may be outside the prostate is an excellent option. So putting a few things together, if you're a urologist in where you live, recommended radiation to be for a good reason and it'd be in your best interest. What about high frequency focused ultrasound? Can you comment on that, Liam? Yes, look, that was a popular treatment about 15 years ago, and it looked like it was going to be fantastic. It's available in small select centres, but it's never taken off, and for that reason, that should tell you that it's not a great option. Is there anything happening with alternative integrative medicine with prostate cancer? There is always things happening. People are looking at diet and exercise and supplements, and that would be a really good talk in itself. Diet is important, lifestyle is important, but it's always evolving. And so part of the problem is the advertising can be a bit creative and people jump on trends. But what is amazing, again, I don't think I'm that old, but in 15 years ago or so since I've been doing this, how men have changed the way they've looked after themselves is just mind-blowing. And the way men's life expectancy is increasing is really amazing.
I've got one more question and then I think I'll hand back, Graham. But this sort of ties in nicely with what you're talking about, Liam. So this gentleman is asking, I was diagnosed in Palmerston North with score 8 high risk in late January this year. PET showed it hadn't spread. What is the best combination of treatments externally? Radiation, ADT, brachytherapy. Will ADT slow it down and let my immune system act more effectively? Is a brachytherapy boost a good idea? Thank you.
Yes, is the short answer. Look, I'll just try and explain that. So ADT is androgen ablation or hormone treatment. So that's Zoladex. And why you give that before radiation is that it helps to shrink the prostate, but also make the cancer in the prostate more sensitive to the radiation, and it's been proven to be effective. The brachytherapy is a brachytherapy boost, so basically a one-off. The seeds aren't left in like what we call low-dose brachytherapy. It's just a literally a one-off treatment with seeds filled with radiation. And again, I'm well out of my comfort zone, but that is something that Leanne Tyree uses quite a bit and is an excellent treatment.
Genetic profiling is likely to influence decisions in some men in the future. And I just noticed that 2 new drugs have just been approved by FDA in America. How do you see this area of genetic profiling and targeted treatments based on genetics? How do you see that coming through? If
it's all right, Graham, I'll just... Yeah. The second slide in medical oncology will come to genetics. So that's fine. If that's okay, they sort of evolve quite nicely. So it wasn't that long ago that if you're on hormone treatment, Zoladex or Leucrin, if your PSA started going up when you're on those medications, there were no other options. It wasn't that long ago. Now there are more and more options every year coming on board. Abiraterone is the standard of care. It's funded by the government. It's an excellent treatment. It's not effective in all men, but it is an excellent second-line option. Chemotherapy is being used more and more. And again, Elliot Bremner is our local oncologist, and he would be a fantastic person to come and speak to you. Enzalutamide is not funded, but hopefully will be in the future. And that's an excellent drug, as is apalutamide. Now, the beauty of all these drugs is that they can be used one after the other. So they're not one or the other. They can be a succession of treatments. And we talk about turning prostate cancer into a chronic disease, and all these things in the armamentarium help men significantly. The other interesting things are instead of Zoladex, so instead of the very popular injection Zoladex, men don't like the look of the needle. In fact, they don't look at the needle. There is oral treatments coming out, which when they come to a decent price will probably take over Zoladex. I think that's quite a way away, and it's being studied currently, but oral medication instead of a 3-monthly depot injection will probably change things. PARP inhibitors, and those are the new medications you mentioned, Graham, they're very exciting, and because that's a whole new level of treatment that attack the gene responsible for being involved with prostate cancer, the BRCA2 gene. Again, they're just early in their evolution, but they look very promising. Now, I'm just going to skip a slide. So just to go to genetics, when seeing men with prostate cancer, family history is very important. And the more you look, the more you find fathers, brothers, uncles with a history of prostate cancer. And what that means is that you need to get the younger members of your family screened earlier. If that's the case, if you've got family members with prostate cancer, it's particularly important when you diagnose as a young man in your 40s, 50s, 60s. That's more likely to be inherited than if you're in your 70s and 80s. Referral to the genetic service if you've got multiple members of your family. So that's really important. What's interesting is the genetic service are much more interested if you've got a history of breast cancer. And the BRCA gene, the BRCA2 gene, they often will find that that's the causative gene, the gene causing the problem if there is breast cancer in the family. I had a chat with geneticists, and what are the referral criteria? All the slide is meant to show that there is not one for prostate cancer. Prostate cancer genetic referral guidelines come under just the top one, just general practice. They assure me that there are some prostate cancer referral guidelines coming, but there are none specific. So that's important for the future. So genetic testing for early diagnosis, but also in the future to have medications which work on the gene, that's very exciting. You know, that's something, it was science fiction not that long ago, but will be a game changer. Yeah. There was a question on lutetium, and this is also exciting. So I talked about PSMA, and PSMA as a test to detect prostate cancer. Well, PSMA with something called lutetium can be used to treat prostate cancer. And what you can see here is, I try and get my pictures, all these black spots are spread from prostate cancer. These are ribs. So this is skull up here. That's skull. Shoulders, I don't think that's cancer. I think that's just worn out shoulders. They look really bad, but I don't think, but there are bony mets or bony spread all through here. And then after one cycle of lutetium, they're a bit lighter, and then the third cycle, they've faded a lot. So this is very expensive. There have been some trials in Auckland. I think they're offering it commercially. It is very expensive, but again, shows a lot of promise for men who normally wouldn't have many options. So there was a question I saw about that.
Yeah, just let me come in and a little bit about that, because there was an item on TV1 News, I think it was on Sunday night or Monday night, and I think there's a question that refers to that, and we've had several other calls at the office about that as well. So there's been a study just released in Australia by Professor Michael Hoffman about this lutetium treatment, lutetium PSMA treatment, and the news item on TVNZ. If you want to have a look at it, you can just Google up their news on demand and have a look at it. And it talks about that, and he's publishing the results of his trial. We funded a pilot study of that with Mercy Radiology in Auckland over the last couple of years. And that treatment, as Liam says, is available in Auckland. It is expensive, but for people who are in the market for that and willing to part with some dollars, it is a new treatment. Again, it's not for everybody, and I'm not recommending it in any way, but I'm just giving that information that for those of you who want to explore Mercy Radiology in Auckland, they can talk to you about it there. Raven, any other questions?
Yeah, we have got a few other questions here at the moment, and a couple of comments. There's some great questions coming in, and there were several about the lutetium 177, so that's great. There's one here, Liam, saying, my son has been tested in Australia, and one of the results is free/total PSA ratio as a percentage, greater than 27% is normal. Little chance of cancer, less than 9% is abnormal, more chance of cancer. Is this result not used in New Zealand? I haven't found anyone who can explain any of this.
it used to be used a lot. It's there's nothing wrong with it as a test. It's just been overtaken by other tests like the MRI. So there are lots of ways that PSA has been used. Free to total ratios is one. The PSA density, like I mentioned, the PSA divided by the size of the prostate is another. Your age, the PSA related to your age is another. There are lots to try and improve the accuracy of PSA testing, and they're all helpful, but things have moved on. It's not a bad test, but so MRI is superseded it.
There's another question on lutetium here. Can this treatment be repeated?
Yes, yeah, look, so you can have more than one cycle. I don't know the limitations of how many treatments you can have, but certainly those pictures I showed you, you had three or at least two treatments.
Liam, any other developments that, or changes, innovations and things you'd like to talk about?
No, that really covers things. I saw there was a question on incontinence. Will we get to just go over those issues, erectile dysfunction and incontinence, or?
Yeah, we can talk about those a little bit. Yeah.
Great.
Yeah. Yeah. Talk about those side effects of treatment, because again, there's good things happening there, aren't there?
Absolutely. So it used to be for incontinence, it can happen after a radical prostatectomy. And the reason why it happens is that the sphincter or the tap muscle that keeps you dry overlaps the prostate. And if you're having surgery, then a part of the sphincter muscle has to come with the prostate to get a good cancer result. And a lot of men, about 90%, will cope with a sphincter that's been cut in half or 2/3, but 5 to 10% will have ongoing leakage and need treatment. And it used to be that the only option was the artificial urinary sphincter, which is a great device. It's been around for 40 years, but it's not perfect. So it's not for everybody. It's not for all types of or degrees of incontinence. So some men have leakage that is only when they're doing gross exertion. They're really exerting themselves, doing heavy lifting. A sphincter is really good for severe incontinence, but not as good a treatment for lesser degrees. And so for incontinence, which is not as bad, then there are various types of slings which are becoming more and more popular and very effective and less complicated. What I mean by an artificial sphincter is that it has three parts, and it's basically a cuff, an inflatable cuff that surrounds your urethra and mimics what your tap muscle used to do. So it's a very ingenious device, but it's a foreign object. It has moving parts, and they can sometimes let men down. And
in the erectile dysfunction department?
So yeah, erectile dysfunction. What's important is being proactive in the men that want to be proactive. Obviously, there are men who it's not a major issue in their life after surgery or even before surgery. But for men who are keen on treatment, it's keen to get onto that, because the erectile tissue in the penis can scar up, and that can make future treatment more difficult. So early aggressive treatment with medication, Viagra type medication is good. Early treatment with injections into the penis can be very effective. Now, they're not funded. They're not particularly expensive, but they are not funded, which is disappointing. But that's unfortunately life in the public system. But if you're more aggressive with trying to get erections back, that increases your chance of getting spontaneous erections in the future. Mm-hmm. If you start aggressively with injections, then medications such as Viagra might become more effective in the future. And then for men who injections aren't working or they don't like, we do more and more penile prostheses, which is an inflatable device to create an instant erection. They are extremely expensive, sometimes covered by insurance, but we do more and more of those.
I should just note that we're actually going to do more detailed webinars on both those subjects later in the year with specialists in those areas dealing with them. And we're also going to do another webinar in a few weeks' time on the CrossFit, our new exercise program that we're getting going. around the country. It's been piloted in Christchurch now for 18 months or so, and is proving very, very effective in keeping men active and mitigating some of their symptoms and conditions and things like that following treatment. So watch this space. Join us again in a few weeks' time. You'll get the details of that in the email that comes out. Raven, any more questions?
The next one is, hi, are there any new developments regarding hot flushes when on Zoladex?
Gosh, not really. No, the standard treatments are cyproterone, which is a very old medication and usually works. Clonidine can be used, but there's nothing new to my knowledge. Often they will settle down. They can be bad early on in Zoladex treatment and then settle down, but hopefully you've tried, or hopefully you could try cyproterone.
It's one of the big issues, isn't it, with men on hormone treatment, is living with some of those side effects.
Absolutely.
So the next question is around, Liam, it's quite specific. What percentage of men have significantly increased prostatism, if I can say that correctly, plus strangury?
Yes. Perfect. Yes.
After the course of radiotherapy, and on average, how long does it take for this to resolve, as in get back to pre-radiotherapy?
Look, that can happen acutely, so soon during and soon after radiation, and usually does settle. It might mean that you had a degree of blockage and that might have been a bit silent before your radiation. So if it doesn't settle down, then it would be worth seeing a urologist or your radiation oncologist in looking into that further, because there'll be things that can be done for that.
Okay, thank you. Another is, this is a follow-on comment, and it's for you, Liam, on HIFUS. I know it has been around for quite a while, but the reason I asked is that I read that recent developments in the US and UK have greatly improved the effectiveness of this as an alternative treatment to radiotherapy.
Oh, sure. Look, in the right man, HIFU would be a reasonable treatment. It's just there may still be available in Australia. You used to be able to have it in Melbourne. There's a good urologist who offered it in Melbourne, but unless you went to one of those centres, you might not get the same results. I would say it's never established itself, and it doesn't mean it's a bad treatment. It's just it needs to be good to be up there with conventional treatment.
Okay.
I think that raises the issue, Liam, doesn't it, of people sort of going through the internet and reading about treatments, that are overseas, and then are they available here? No, are they not? Some people even go to the extent of then exploring those, spending enormous amounts of money. I know I met one gentleman, he wanted to find the best urological surgeon in the world, went to New York and spent an enormous amount of money, came back, and he still had continence issues, probably no better than he would have had with one of you local guys. So, how do you get around that? People looking offshore, people thinking, there's better somewhere else. My view is that we've got excellent practitioners here in New Zealand, haven't we?
That's right. So, look, we know lots of people have that same experience. They go overseas and don't get what they thought they would read about their experience. And so, you've got to be wary of marketing. And look, the quality of New Zealand urologists and urological training is very high, and our surgeons work around the world and, are well rated. So, look, they're a dynamic bunch, and they're always trying to improve their care and techniques and outcomes. And so it's not necessary. There'll be men who always go overseas, but they should be reassured that that's not necessary.
So, Pete, any final comments you'd like to make as we sort of begin to wind this webinar up?
Well, maybe thank you for putting this together. I'm not sure I should use the word excited about Pete and I starting this up, but we're very keen to get this going. It's been a long gestation period, but it feels like we're really there, and this has been a good kickoff, and we just look forward to meeting people when we can have the first physical meeting, which is hopefully in a month's time. So thank you.
Yeah, I'd fully endorse that. I'd just like to acknowledge the best thoughts and best wishes from the support groups as well that are coming through, like Catty Cat, Silwan.
Yes.
That's awesome. So thanks for that support.
Liam, any final comments?
No, well done. And anything you need, let us know.
Great, thank you. So just let me just wrap the webinar up. The team at PCF, we're now back in the office and we're all working at full capacity. So we're available to provide support and information. So if you need to get hold of us, you can give us a call on our 0800 477 678 or through the website or through our email addresses that you'll find on the website. We've all got a pretty active Facebook page, so you can look at messages and things on there. Liam, thank you for providing your expertise and insights today. Ian and Pete, really thank you for taking the initiative to get this support group going, to get it re-established in Tauranga. We really wish you well with that. I'm sure it's going to be a success, and you know, you've already got people lining up to come along, so it will be great. And if you're not in Bay of Plenty, just to let you know that PCF does have a strong network of support groups around New Zealand. There's about 38 groups currently, and all the details of those are on our website. But if there's not a group near you and you'd like to explore getting one started, then please contact Raven. She'd be delighted to hear from you. And again, you'll find her details on our website. So just finally, I'd like to say thank you all for joining us today. As I've said through the webinar tonight, we'll send you an email with a link to the webinar, and there'll be a link to the recording of that. And so you can watch it, or you can pass it on to other people to watch at their leisure. And the details of this first support group in Tauranga, and also a survey, which we'd really appreciate you completing. It helps us to plan and improve on these webinars that we're doing. We really appreciate that feedback. So we wish you all well. Keep safe, and good night from us here at the Prostate Cancer Foundation. Thank you.